So it's really a pleasure to be here today with everyone, and it's been a fabulous morning. It's so nice to meet all of you and connect. And I just, from a show of hands, who are the dentists in the audience? Okay, great, because this was going to be somewhat of a dialogue as well. So I'm glad I won't be talking to myself. So, can you fix my broken tooth today? And I think that we have all come across that scenario in our daily lives as general dentists and practitioners. And over the years, that concept has really morphed for me in my private practice, and especially in the anterior zone. So I hope that today I do a little bit of justice to this controversial dialogue and we can have fun discussing it together. So, Dr. Lee Tran told you guys a little bit about me and what I do and how I'm involved. And I especially love working with new dentists and residents, especially in the New York area. And one of the ways in which dialogue has changed in dentistry, it's become less about just materials and procedures, and it's become more about like wholesome care, beauty, and we've taken on various roles now in the industry that I don't think we had to in the past. So we've become estheticians, become doctors, we've become friends and confidants of our patients, and these are all different pieces of a puzzle that we as dentists have to put together to bring, our patient to where they want to be. And of course, aesthetic enhancements are a big part of what we do day to day. And we all know that there are these golden ratios and these concepts of beauty, and the media also adds a lot of fuel to that fire. But, this day and age, we're lucky that we have a lot of tools at our disposal to help bring people to where they want to be. So, on a day-to-day basis as practitioners, we come across various concepts like hue, chroma, value, and now we're not just dealing with them by tooth, we're also dealing with the patient's entire face and head and neck area. And this has become mainly because of all the apps out there and the social media out there and the multi-million-dollar market that exists that we now have to help our patients achieve. And if you take out your phone, and you're all welcome to do so, these are just some examples of apps. And we have a lot of fun in our practice with our patients. We turn these scary, intimidating office visits where people come in with a lot of phobia about what's going to happen into a very fun, welcoming, and creative office visit. And it's a great way to create buzz about a service that you provide in your office that's uplifting and that makes people feel good about themselves. So if you take out any one of your social media apps, and I don't know how savvy everyone here is with using filters and other kind of things on TikTok and Instagram, but people can give themselves makeovers within a couple of minutes now. They turn into looking like the person that they always wanted to be without actually having to go through any painful procedures. So how do we help them in our private practice to mimic that look and help them achieve these things that they want that they can't have unless they're on social media? Well, now we do. We have lasers and we have a lot of other things at our disposal that helps them preserve what's naturally theirs and helps them feel good about themselves. And of course, if this had been a hands-on, which it was supposed to be, we would have done a little virtual plastic surgery exercise together. There are many apps like the airbrush apps and the photo collage apps that really help our patients learn how to do these things. So the first thing we do in my practice now, no matter what a patient comes in looking like, we learn how to smile. And why do we do that? When your patient smiles, you as a practitioner see a lot of things on their face that they don't know you're looking for, but you are. When your patient smiles, you're seeing their nasolabial folds. You're seeing how high or low their lip line is going to expose their front teeth and their gingiva. You're seeing lines by their eyes, on their foreheads. So you're getting a very intuitive look into how your patient perceives themselves. When they smile, are they kind of covering something up, Are they exposing everything? This is a lot of information for you that you can't really dig into or delve into when they're filling out just paperwork, or when you walk into the room and you take a bunch of x-rays on them. This is invaluable to you, your client, and your future relationship with that person. This is telling your patient that you care about them, you care about their image. So, like I said, the first visit is a very anxiety-provoking and phobic visit. You want to make sure it's serene, positive, set good expectations, and be transparent. We're looking to educate our patients. Okay, so who in this room is familiar with an iTero and has one in their office? Okay, well, anyone in the audience, if you have your iTero with you, you know that that's one of the first most fun and useful pieces of technology in your practice. When you go over the iTero occlusogram with your patient, they're seeing something they're familiar with. They're seeing kind of what they see when they turn on the news and they look at the weather. They're understanding in a fun, friendly way how their teeth meet. They're able to see through their teeth with a laser any microfracture lines they have and understand in a very user-friendly way how their teeth are meeting, what needs to be done, and where they need help. So cosmetic enhancements, when we take a deeper look, equate to glamour, beauty, feeling natural, having balance, symmetry, and of course, any enhancements we do help to brighten up their smiles. And the anterior dentition is your patient's first impression. They're the teeth that are most frequently damaged. They're the teeth that determine their vertical dimension, among other things. This is also an area where you may look to do Botox or fillers to help them with a black triangle they don't like or gingival display that they don't like. And there are a lot of well-accepted thoughts. So when you tie all of this together, what are you in essence trying to do? You're trying to help your patient preserve what's there, what's naturally theirs, and help them maintain their youth. Any type of surgical procedure you do on your patient, you're taking away something natural. You're lowering the prognosis of that tooth surviving. You're lowering the prognosis of them having what's there and conserving what they want to hold on to the most. Remember, everything we do in private practice is a form of surgery. It may not be something that they want, and it may be something that causes a lot of fear. So as we talk about the broken front tooth, we know that a lot of times these are the teeth that need endodontic treatment. These are the teeth that need to be pulled and have implants placed. Study after study shows that endodontic treatment on teeth weakens them. Removing teeth and placing implants has its own set of complications. So, as we move forward with the presentation, I wanted to talk to you about anatomical variations that we should consider when we're replacing missing anterior teeth or premolars. We have to remember that there's a lot of unknown that can only be seen with CBCT scans or by further assessment of each and every single tooth. So these pulpal variations that occur can be seen in this diagram. And for many of us as practitioners, we think we're going to dive right in, place a post, place a core, and that's going to be success for us. Let's just keep in mind that that's not always the case. Especially in the premolar area. The premolar area frequently is the inhabitant of the buccal corridor. We want to make sure that we're conservative when we treat these areas, and we want to make sure that our patient understands the pros and cons of restoring or not restoring these areas on their natural dentition. Endocrowns are tricky, and I see them quite a bit in private practice. One thing I note about them is that a lot of sound tooth structure is obliterated when we have to go ahead and treat these. for when they do fail, going in and having to retreat this area is very challenging, and it usually ends up in an extraction and implant placement. So as a general dentist, if you see a tooth that's endodontically treated, especially in the premolar area, make sure you consider placing a post very seriously in addition to your core buildup. Now, there are studies that show that placing posts on premolars can be very tricky because of their anatomy. So make sure that you take a CT scan and take a very close look at what materials you're choosing to place. You want to be very conservative with your post placement, and you want to use a core buildup material based on adhesion properties. And we know there are a wide array of posts available. My new favorite in the practice is, of course, fiber posts. They're the most aesthetics, and they work well with adhesive dentistry. Now, when you place your post, of course, you want to consider your ferrule. If you have enough tooth structure, move forward with just a core buildup. Placing a post has become the norm because of insurance reimbursement and finances, but don't fall for that too quickly. And of course, we want to review some etching and bonding techniques. Who in this room is a fan of the total etch in all adhesive circumstances? Great, I'm happy to see that. So my practice has also taken more of a turn towards selective etching and self-etching. And it helps to, get those collagen fibrils ready for uptake of materials. Now, one of my favorites for just core buildup material has become the Kettenbach system, which is the Visalis SEM core. It has a wonderful active connect technology, and it also has MDP and silane methacrylate primers that are useful for bringing everything cohesively together. The tooth structure, the core buildup, and your final restoration. And of course, we all know there are desirable qualities for every core buildup material. The most important is that it has dentin-like capabilities so that it can really tolerate all the biting forces. And the properties of very good trending cement are you want low viscosity, good flowability, and this creates a thixotropic material. You want it to have high self-cure mechanics, long-term adhesion, and user-friendly handling. You want low water sorption and dentin-like grindability. So in a case like this, from the dentists in the room, I just want to take a poll. Who would place a post on this and restore it? Okay, and who wouldn't place a post on that and restore it? Okay, can we all share ideas about why or why not? I'm just curious to know because this is something I see in private practice a lot. And I will tell you that after placing many implants on these type of teeth, I can tell you a lot of them are a lot stronger than you think they are. And I try my very best personally to save them and put posts in them and restore them. But I would like to hear why people feel one way or the other.
Well, first and foremost, I guess the practice I practice in is more of a lower socioeconomic type practice. And so my goal is not to confuse them or scare them with implants and the expense, and also my confidence ability to do a root canal post and build-up is far superior than it is to put an implant in. We don't do them every day. It's a lot of armamentarium. I have to, get it all set up. I have to make sure I've got the right assistant. So therefore, when I look at that tooth, I would get out my electrosurge, zip, zip. If the endo was good, I would use the same endo. If not, I would have to retreat it, put the post in. I'm very confident with endo, post, and core buildup.
I appreciate that a lot. And you said no post.
Well, in this case, probably not a post because if I had an adjacent tooth, I would. But because it's right there, I would not because, if you're going to have a partial and it's but before partial, then usually in my case, I've seen those fail more than not.
Okay, fair enough.
Yes, I have a question and a comment.
Yes.
So the question is, you put a post, dildo, and crown on that, how long does it last? And the comment is, can I give your cell phone number to Dr. Paul Goodman so we can have a debate with him?
Well, this is why this makes for a great new dentist and resident lecture, because now, as you guys know, every other young dentist is placing implants. And so in the past couple of years, I've done many immediate extraction and implant placements. And there are times when these teeth are coming out and they put up quite the fight. Don't let the color mislead you. They're not as weak as they look. And I now tend to reach for my multicolored cement and core buildup material more often than not, because a lot of these teeth, if you zip around it a little, clean up the gingiva, disinfect it, cut back the gingiva just a little bit, and do your crown lengthening properly, these are great teeth to keep in the mouth and restore. And that's why I really like the name of this lecture, is because you can save a lot of these teeth and you can give your patient their tooth today, especially if you're milling in office. I have done also my fair share of immediate implant placements on these with same-day restorations. There is a large amount of risk that goes into placing an implant, and it's quite risky sometimes. So I would encourage everyone to find what works best for them and to restore these teeth, especially this one that you're looking at, which is a canine. That root length is fantastic. So this is one of those scenarios where, you know, it leads to a lot of discussion, because the thought process now is more and more towards implant placement, and this is where I like to be really conservative, especially in the anterior. That natural tooth structure has a lot to offer. Thank you everyone for participating.
Let me also validate your, I've switched from the metal flexi post, which I used to love, to the fiber post, which I love even more.
Agreed. I couldn't agree with that more. So I would say I walked into a practice where we were placing metal posts, and fiber posts and adhesive dentistry have done wonders on a lot of teeth that we would think are hopeless. So another thing I commonly see in private practice, and this has been going on for ages, is that broken front tooth. Various things can happen, accidents happen, people come in and they're traumatized, especially because now they're aware more and more that not having teeth is not really an option. It's very important to have sound, good-looking anterior teeth. So let's take this case, and you know, I like this case because it was one of the first times that I was glad I had on hand core buildup materials that were very strong and aesthetic that I could layer. And I walked into a practice where you put in a metal post and you just used a very mundane looking cement. And I liked that for this particular case, I excavated decay, and I know I had a broken front tooth, and I was actually able to use a core buildup material to shade match. And I liked that in the future, when I went in and prepped that tooth, the feel of that tooth was not like cutting or, you know, prepping composite. The material very much felt and mimicked dentin, and it was able to kind of hold my final restoration in a very nice way with a minimal preparation, where I held on to a lot of the tooth structure. In my practice, more and more now, I'm doing smaller veneers or mini veneers, mini restorations, and especially with the beauty of porcelain and Emax these days, or even zirconia, you don't have to really prep these teeth too much. So let's look at a fun case that I did, and this was a 69-year-old female. Her teeth had actually been restored by a prosthodontist. She was very happy all these years with the way everything had worked out for her. But what do we notice here? The aesthetics is not that great. This is really a nice, well-balanced occlusion, and these teeth have served her so well over the years. But we notice that, this is kind of the old looking, not that aesthetic porcelain on these teeth. And from the photography, you also see that aging, okay, showing more of the anterior dentition on the lower. So in my opinion, I felt like the anterior front teeth also needed to be elongated a little bit. Now, photography has taken on a bigger and bigger role in my practice because a picture is worth 1,000 words. You never want to tell someone that their front teeth are not that great, or you don't think that they're great. No one wants to hear that, and there's no really nice way to say that. But when I do my smile simulations, which are my smile mock-ups for my patients, and I show them what their teeth can look like when they're longer virtually, or what we can do to change the shapes of their teeth, all of a sudden I see their faces brighten up. It's like being able to shop online, but also being able to try the clothes on. Instead of seeing like a generic model, you have a picture of yourself and you can put the clothes on yourself online. Wouldn't that be a very cool way to shop? Well, now your patients can shop for their smile that way. And they can try on their smile without having a lot of goop in their mouth, without having any kind of pastes that don't taste good. This is going to have that psychological effect on your patient that a number of other things won't. And this is why treatment is happening faster in my practice. And we're getting through cases so much faster now without insulting people. We're able to help them move forward very quickly. And what we do is we look at the positioning of their eyes, we look at the tip of their nose, where their chin is, and a few other landmarks on their face. And we build their smile custom to them. But it gets better. We now also airbrush our patients, and we put some makeup on them. We make them feel and look good and anti-aged in the practice. So how do we do all of this? Well, we use fillers, we use Botox, we use lasers, and there are a lot of ways to get your patient thinking about how they looked 10, 15, or 20 years ago on that first visit without scaring them and without being negative. The tone of all of this is very positive. Everyone has an iPhone. You have an iPhone. So start downloading these apps. Have your patients taking their selfies. That's the one good thing I think COVID has done for dentists. It's gotten our patients on Zoom calls. It's gotten them projecting parts of their face that they never thought were unpleasant looking. And then, of course, we use these apps to help our patients pick what shape they like for their teeth. And we now know there's no such thing as manly teeth and feminine teeth. Masculine and feminine doesn't really exactly exist. It's what makes sense on our patient, and that's important. And of course, for the dentists in the room and in the audience, you already know we take shades, we're doing things as we have for so long, but we're getting to that place to help our patients in a much more fun and relaxed way that's non-intimidating to them. So now we know when we look at this case, a lot needs to be changed. She doesn't exactly have the incisal edges, the incisal translucency. The teeth are not as aesthetically pleasing as we now know we can make them. And of course, you see from the occlusal photos again that these are teeth you really want to hold on to. They've done this patient a lot of good service, and they continue to do so. They're just unsightly as we know them because of the hue, chroma, and value having gone downhill. So again, we talk to the patient, we show them, they like seeing red and blue and green and yellow. that's something that's close to home for a lot of them, because they're not seeing scary, they're not seeing or feeling pain. And of course, for those who are doing any orthodontics in your practice, you know that's another great non-invasive way to avoid surgery, to realign the teeth, and to bring your patient to a final result that they really enjoy. So in this particular instance, when I removed these crowns, I wasn't sure if I'd have to go in and do any extractions, any endodontic treatment, but I did find that I had very little tooth structure underneath to work with. And that's when I reached for, in my armamentarium, a material that would be great as a core buildup and a cement. What I did was take this impression and send it to the lab and ask for a little bit of extra die spacer material. So I didn't have to go in and build these up. I used wonderful colored cements to help me block out what was underlying and unpleasant looking. I put her in temps, and I had to sit down, and the only thing I really found myself doing was wondering which of these shades I'd want to work with if I put lithium disilicate or porcelain on those front teeth. And I ended up working more with an A2 and a bleach shade because I wanted to block out what was underneath. And, you know, that was a very creative way to go about this case, whereas I think a lot of dentists would have felt like they should go in and do a core buildup with composite, or they should do endodontic treatment on them. And I didn't feel the need to do that. I didn't feel the need to weaken those teeth because they were very strong and they had done well by her all these years. That decision in and of itself made that patient feel young and vibrant. She felt good hearing and knowing that we were able to use her existing dentition to do great final dentistry on her. And this was her final outcome. She was incredibly happy with that. And the one photo I take more and more now in my practice is the 12 o'clock position, because I see the relationship of those anterior teeth with the lower lip. And for those who are involved with any type of geriatric dentistry, nobody wants to see their lower teeth or anything unsightly except for their beautiful white anterior dentition. So again, this kit that I used and have started to really, really love over the years gives me various shade options, especially for handling these front teeth. And you build up the teeth in your office, you mill everything, you cement it, and using different shades, you're able to restore your patients to good health on their smile. So again, we went over the whole dialogue with premolars, which in my practice, a lot of doctors kind of consider their premolars to be posterior dentition. First premolars really fall into the buccal corridor area, which for me is part of the aesthetic zone. So again, these are teeth when the patient comes in and they're missing a first premolar. That's a problem for me. It's definitely a problem for them. We go ahead and restore those teeth same day because it has a psychological impact on your patient to be walking around without a first premolar. Even though it's not the anterior dentition, it's definitely a part of their face that falls in the frontal zone and shows in their smile line. So some conclusive thoughts are desirable qualities of a dual cure and light cure core buildup and luting agent that make it favorable to use are high self-cure mechanics that give it stability under our restorations, high bond strength for long-term adhesion, user-friendly handling and excess removal, aesthetic colors, and a balance of flowability and stable consistency to allow for versatility are what you should be looking for. So, in conclusion, thank you, and I definitely wanted to thank Kettenbach for supporting this talk, and I hope that I gave you all a little bit of insight on how to work with your patients and make them feel good and to really transform your practice into one where you're using more pain-free, feel-good techniques for smile enhancements. So thank you, everyone, and thank you to my dentists in the audience who participated.